Hello, my name's Alan Lumsden and welcome to DeBakey CV Live. This afternoon we're going to focus on the training of the cardiovascular surgeon of the future. So I'm a vascular surgeon.
I'm Tom MacGillivray, I'm a cardiac surgeon.
And I'm Marvin Atkins, I'm both a cardiovascular surgeon.
So
Thank you for having us.
That's kind of what we're here to talk about this afternoon. When I came down to Houston, Dr. DeBakey was still around, and the word cardiovascular surgeon was completely pervasive. At Emory, I never even heard of that word being used. There were cardiothoracic surgeons and there were vascular surgeons. In Houston, everybody was a cardiovascular surgeon. And I bristled at the concept because I was traditionally trained, or boards in cardiothoracic and boards in vascular. Somehow or other this got all messed up here. Part of it was the legacy. A lot of those procedures were being developed here at Methodist and in Houston. And we often think of Dr. DeBakey as being more vascular than cardiac surgeon. Dr. Cooley, everybody thinks of more cardiac than vascular surgeon. So, Tom, you come from a very different background. What was it like up in Boston?
So in Boston, it was very much, there were cardiothoracic, it was actually cardiac surgeons, there were thoracic surgeons, and there were vascular surgeons. Certainly the training of cardiac and thoracic surgeons were the same. And it still is the same in terms of the board and the board requirements. But where I came from, we either were cardiac surgeons or thoracic surgeons, and very rarely did that get crossed. The vascular surgeons were, again, completely separate.
So then, Marvin, you came along.
Yeah.
Messed up the whole picture. You tell us a little bit about your journey.
Yeah, so my training began back in 2000, finished general surgery in 2005, went up to the Mass General in Boston and did a 2-year vascular surgery fellowship with Rich Cambria and the other faculty there. I actually worked with Tom MacGillivray when I was there, a few cases which overlap between cardiac and vascular, and had a pretty busy vascular practice, so doing endovascular aneurysm repair, open aneurysm repair, and had a pretty good experience with thoracic and thoracoabdominal aneurysms, both open and endovascular. Subsequently moved back to Texas and was in practice for about 10 years, had a busy practice doing carotids, lots of aneurysms, not a huge volume of thoracic and thoracoabdominal cases, but a decent volume. We started a training program, had fellows, and what I found over time is that the open volume, just as is everywhere in the United States, continued to decrease. And I found myself doing fewer and fewer open thoracoabdominal aneurysms every year. And it came to a point where I kind of had to, decide, was I going to do the patients justice by just doing a few of these per year? Or is this something that I just was going to take out of my practice and abdicate and refer those patients on to Houston and other centers that do a larger volume of these cases? Because clearly these are complex cases. It takes more than just the surgeon. It's the ICU team, the anesthesiologist, and the total care package that provides the ultimate best results for these patients. And so I kind of had a long discussion with my wife over several years and felt that the best option for me to continue to do those cases would be to get further training in cardiac surgery, which was dealing with, open dissections, open arch cases, and more open aortic surgery than, the vascular practice that I had, which was, having diminished aortic cases every year. So I made the ultimate decision back in 2017 at the age of 43 to go back as a super old fellow to the University of Pennsylvania and work with Joe Bavaria and the group there that has a busy central aortic practice. So I spent 2 years there, and the final year, Dr. Bavaria had usually had taken 2 aortic fellows every year, and my year he took no aortic fellows, and so we were able to, our senior year, move into the aortic fellows spot and basically spend an entire year with him doing aortic surgery, in addition to all the rest of cardiothoracic surgery.
So when you were applying for CT fellowships, what did they say? Do you think you were
probably about half of the interviews started off with "Are you crazy?" as the first sentence. But I
hope you didn't say no.
I had my reasons. I had it logically kind of thought out in my mind and able to express that to people that I had a really big interest in aortic surgery and didn't want to give that up. doing mostly endovascular types of cases, and wanted to continue to have a robust volume of open aortic surgery, and that was my kind of selling point for fellowship. The funny thing is, 3 of the attendings that were there were my junior residents way back when, so it was fortunately things went well way back when, so it was kind of an easy transition for me.
So what do you think, Tom? We're still trying to figure out if you're crazy or the smartest guy we know.
I think a little of column A, a little of column B.
That's right.
It is interesting. I think that I don't think, certainly in cardiothoracic surgery, we know yet. There are currently 3 different pathways that an interested resident can take, or an interested medical student can take, to get into cardiothoracic surgery. There's the traditional tract, which is you finish 5 years of general surgery and then go in and do a training program in cardiothoracic surgery. There's the integrated program, which is 6 years, that you start right out of medical school and finish 6 years of CT surgery. And then there's the 4-3 program, which you go from a program that has a cardiothoracic surgery residency, and you can do 4 years of general surgery and then 3 years of training. And the last 2 are still relatively new, and I don't think there's really any data to show whether any one is better than the other, or if all are good.
I think there's also a 4th training pathway now that's been approved by the American Board of Thoracic Surgery, is doing a 0-5 vascular surgery residency followed by a cardiac surgery fellowship.
Yeah, correct. Yeah, which would, I think that falls under the traditional tract.
Correct.
You know, the challenge is that certainly when these other pathways were being created, there was the worry that training was just too long. That if you had people go through general surgery, and then oftentimes you had to do a couple of years of research, and then do 2 or 3 years of training, that people weren't interested. It was just too long of a training program, and so there was a real interest to try to decrease the amount of time. The problem is, there's more information to learn. There are more techniques to learn. Back when I trained, the techniques that we used in cardiac surgery were very similar to what you learned in general surgery. The difference were that the threads were smaller, the needles were smaller, and the instruments were longer. Other than that, the techniques were the same. Now it's very, very different. And so we're faced with the challenge of having more things to learn and less time to learn it.
So there'll be an opportunity to text questions in this afternoon. You actually text the questions in. We're going to put that up as a banner. You text DeBakey to 37607. That's DeBakey to 37607. You can also follow us on social media at DeBakey CV EDU, and you can follow us on YouTube, Facebook, Twitter, and LiveStream. So one of the things that prompted us to do this is that on the vascular side, just to recapitulate the vascular training models, there are essentially 2. You either do 5 years in general surgery, 2-year vascular fellowship, some people throw in a year of research, or along comes the integrated vascular program. Now I can tell you that up front, I was not a big fan of that idea at all. You know, I'm more than happy to admit that I think I was wrong about it. It increased the interest in vascular surgery. And, you know, although there's subtle differences, overall they're very competent people who are coming out of that program. But we live in a department of cardiovascular surgery where cardiac and vascular surgeons are all kind of in it together. And one of the strengths of that, I think, is that the vascular surgery trainees rotate on heart surgery.
Correct.
So 2 of our 4th year residents, we only have 2 per year, now want to go into cardiac surgery. And it was fascinating, first of all, that they decided they wanted to do that because they found the things that you're doing very exciting. And then as I started debriefing with them about their interviews, the amount of interest there was in cardiac surgery about hiring somebody who'd trained in vascular. And the kind of comments that came back were, the general surgery residents don't really even do hardly any hand sewn bowel anastomosis. They're kind of stapled. We have to train everybody how to do a vascular anastomosis. You're going to come out trained, and you're going to have endovascular skills at the end of the day. So the kind of light bulb went off, and I thought, well, you know, maybe DeBakey was right. Maybe he was right about a lot of things. You disagree with DeBakey in these here parts, that's your pearl, so I'm certainly not going to do that. And so, you know, it comes back to this idea, if you're going to build a cardiovascular surgeon, it's kind of like what you've done. Right. But hopefully you don't have to go back.
Not to take
your mid-40s.
17 years to do it. Yeah.
So,
no, I think that's a great point. You know, having the wire and catheter skills, especially as cardiac surgery is changing these days. So with structural heart, all of the transcatheter therapies for aortic valve replacement, mitral valve clips, and now transcatheter mitral valve repair, the vast array of transcatheter options for these patients is going to continue to increase. And being able to have wire catheter skills beyond just passing a wire into the aorta, but being able to cannulate things, use different types of catheters, and all those skills that we learned as a vascular surgeon really puts you a step ahead, you know, compared to traditional cardiac surgery trainees.
Tom?
Yeah, I mean, it's funny. You hear that cardiac surgeons are becoming more like cardiologists. Cardiologists are becoming more like cardiac surgeons. And I do think that there is, as we find out newer, better ways to take care of the same disease. I mean, in the old days, it was easy. Cardiac surgeon, or surgeons did surgery, everybody else did not. And I think as the interventional role of some of the medical specialties have evolved, and as the interventional techniques that surgeons have evolved, we become more together. The challenge in cardiothoracic surgery is, sure, vascular surgeons are very much like cardiovascular surgeons, but for those residents who are interested in doing general thoracic surgery, certainly I think there is great benefit to getting a general surgery exposure and dealing with the foregut and spending more time understanding the principles of surgical oncology. So that adds to the problem. Now we keep adding more things to learn.
Correct.
And we don't take anything away. So do we have enough time? I didn't even get into congenital surgery, but do we have enough time to teach the residents what they need to know in order to be able to take and pass their boards and to be competent in all of the aspects of cardiovascular and thoracic surgery?
I mean, in my opinion, thoracic surgery these days, with the use of robots, VATs and thoracoscopic instruments, all the surgical oncology that goes along with that, it is much closer to general surgery than it is to cardiac or vascular surgery.
Agreed.
So we were going to change it? I mean, I've been listening to you. I mean, one of the challenges is we all come out of traditional academic specialties with typical tracks, and they've been built really 20, 30 years ago, that these were the models that you trained in. We really have changed them a little bit, but I mean, listening to you, it's almost like the thoracic surgeons need to come out of general surgery and the cardiac surgeons should come out of vascular surgery would be kind of the ideal. Clearly there can be some crossover.
You know, I think a lot of it really depends upon the practice that you have after you get out of training. So if you are in a large academic medical center, you're going to have cardiac surgeons, you're going to have thoracic surgeons that typically are not, may not even be like they are here, not even in the same department, much less really have much overlap or interaction between cases. The trouble becomes for surgeons if they go out into community type of practice, they're expected to be able to do everything, vascular, cardiac, and thoracic.
Marvin, that's a great point. When I was a medical student, I did an elective in Kenya, and I remember at a meeting that they said, you know what, the way we train people, you build the cake and then you cut these vertical slices. And they said for a developing country, and I'm not talking about rural United States going at the same level, but they said you need to cut the pie horizontally. And it's a little bit like that in that we train specialists, but the community away from the big center needs generalists.
Correct.
But we don't regulate them in that way. We don't give privileges to the same extent in that way. And their boards are certainly not built that way.
Right.
And so should we be building community surgeons? Don't know. Tough one.
Yeah, it's a tough one. And we have a question up there about should cardiac and thoracic surgery be separate specialties?
You want me to handle that, Tom? So you're off.
That's a third rail kind of question. But you know, it's. I mean, I would say that yes, I think cardiac and thoracic surgery are very different now than they were 30 or 40 years ago. I mean, what united cardiothoracic surgeons was the chest cavity where we both operated. Mm-hmm. I would venture a guess that I think that those physicians, whether they be surgeons or interventionalists, that do wire skill techniques will not be the same group of specialists who are doing open cardiac surgery. I think it's a different skill set. I think that you can be superb in one and not necessarily the other. There may be people like Marvin who are superb in both, but they are going to. I mean, it's going to be just in our lifetime. I mean, I think that if you look at what is now considered to be a straightforward EVAR compared to, TAMBI graft, I mean, it's a very different skill set. And if you want to stay not just in the aortic space and the peripheral vascular space, but getting into the structural heart space, that is, as we say, that's a full-time job. So, I mean, I think that maybe we are going to have to continue, maybe we will become like cardiology, and there will be, different subspecialties, and I think that the focus and the training will need to be more and longer.
I think the difficulty is you don't want to be a jack of all trades and a master of none. I mean, patients deserve the best care, the best, latest, options for their disease process, and surgeons that are able to provide whatever the latest cutting-edge technology is to help them through their problems in hopefully a minimally invasive way if possible. So I think we have to carve out subspecialties, and that's somewhat what's happening in cardiac surgeries these days. So after cardiac surgery training, it's very frequent these days for somebody to do a super fellowship that's either 6 months or a year in either aortic surgery, transplant, mechanical circulatory support, structural heart, or congenital. Those are the kind of the usual 4 pathways that people tend to go if they're going to do some type of subspecialty training.
Right. And again, as you pointed out, that's great if you're going to be in a big, busy academic center. Community hospitals really won't be able to literally afford to have an aortic surgeon and a coronary surgeon and a mitral valve repair surgeon and a structural heart disease surgeon. So somehow we're going to have to strike the right balance, and there are countries that regionalize care. I don't think that's something that we nationally are
ready for,
ready now or may never be ready for. But it certainly should be taken under consideration as we try to further shape or create new training paradigms.
It's interesting because Michelle Macron was the president of the SVS a year and a half ago, and his presidential address was pretty controversial because one of the things he espoused, and talked to him about this, is should we be training general surgeons in the community how to do dialysis access? Should we be teaching them how to do femoral embolectomies or something like that? In other words, what is a society to try and improve the general cardiovascular well-being of the population, or is it to protect me as a specialist? And I happen to believe it's the former. And so it comes back to this question of the community surgeon. Do you think a general surgeon can be trained to do a thoracotomy and a lobectomy, for example? Or maybe that's a bad example, but are there areas that we should be training the broader specialist, non-specialist in the periphery to do? A lot of societies go, absolutely not, and that's part of our boards, we're not going to train other people to do it. I have a slightly different opinion on that.
Yeah, I mean, it's my dad was a general surgeon, and back 70 years ago, general surgeons were a specialty. Back when he did his residency, 2% of physicians in the United States were specialty trained. Wow. Everybody else was a general practitioner. We don't think of a general surgeon as being a specialist, but that's in fact what it is. And he did everything, and I would say he did everything very well. But he was trained to do everything, and I think that as I mentioned earlier, whether he was doing a gastrectomy or a colectomy or a nephrectomy or a lobectomy, the instruments and the techniques were all the same. It was just a different place where you put the incision. We've come a long way in terms of our techniques and our technology, and I think the ability for one specialist, as Marvin pointed out, to do it with the highest level of quality and safety, that's a tall order. Can they do it? Sure. Should they be able to do it? Sure. But can we train everybody to do that? I'm not so sure.
See, I think the trouble, at least for a general surgeon, if they were doing some type of thoracic case, using a robot or doing some type of video-assisted thoracoscopic procedure, would be very, useful. They would feel fairly comfortable learning the anatomy, and some other, dissection techniques may not be too different. But the trouble becomes if they had to convert to open or they got into bleeding. That's where they may not have had significant open experience might be troublesome.
Pick up on that a little bit, because I'm going to quote Sam Money. Sam Money was at Scottsdale, now he's going back to Ocean Clinic. And he showed a video at the Society of Clinical Vascular Surgery, and it was nutcracker syndrome. We moved the renal vein, disconnected from the via vena cava, moved it inferiorly, and reanastomosed it. It was the most beautiful exposure that I've ever seen. Right. Pretty complex vascular operation. Then he said, but I didn't do that. My urologist did it.
Sure. Okay,
so to the point, maybe you should be credentialed based upon the instruments that you use rather than the operations. Or the robotic vascular procedures done in this institution are largely done by the urologists, right? Because they're doing inferior vena cava tumors. They don't get vascular credentials, they get urologic credentials. But they do it, and this is one of the things that worries me a little bit about the vascular surgeons, is our people will not come out anymore trained in laparoscopic surgery. They're not going to have that skill set. Right. Whereas if you do go through general surgery, you can pivot to wherever the technology is taking you. But we really, have lost the endovascular capabilities that we once had.
Right. Yeah, one of the most inspiring lectures I ever heard was from Murray Brennan, who was the chief of surgery at Memorial Sloan Kettering, and he cautioned against that. He thought that we're physicians first and we're surgeons second, and that rather than focusing on a particular technique, we should really embrace a disease or a group of diseases, and we should evolve how we take care of those diseases appropriately. So those oncologists, they're not cisplatin doctors. They're physicians that take care of cancer. And once a new therapy comes in and proves to be better, you adopt it, you adapt to that. And I would think that that's what we should continue to do. I certainly when I started, surgeons were doing thoracotomies and cabbages and doing relatively straightforward congenital heart surgery. That was all within the scope of practice. I think that doesn't happen very much anymore. I do think that maybe we need to, as Marvin pointed out, we have to start with a general overview and then subspecialized. And I think that those residents who want to do general thoracic surgery, they take a different road. Those residents that want to do cardiac surgery, whether it's aortic or structural, they take a totally separate road. And those who want to do vascular surgery, a third separate road. I don't know. It's easier said than done.
We have a surprising number of questions coming in, so maybe we'll kind of pivot and see if we can take some of those. How is CV surgery evolving in relation to the interventional field? You work with cardiologists every day.
Every day.
Both in referrals and in the heart team, and doing TAVR, for example?
So all of our cases, obviously the patients get referred to you typically by a cardiologist. We usually have some type of multidisciplinary discussion about all the patients that we're going to operate on amongst a heart team. So we've taken the heart team concept that was started initially with structural heart, and at least where I work, we've moved that out into basically all types of procedures. So all of our coronary cases, valve cases, aortic cases, anything that's going to be operated on gets reviewed first by a multidisciplinary team to make sure that everybody's on board, that everything is done correctly for the patient. So we have a great interaction. I think that builds camaraderie among a team. I think when you get to difficult cases, these patients, or these referring physicians a lot better. You've worked with them on a daily basis, and it's really made for a great team kind of concept to extend it beyond just structural heart, which is what happens probably in most hospitals these days, I would imagine. The heart team is really concentrated just amongst structural heart.
Correct me if I'm wrong, but I mean that's mandated for TAVR.
Correct.
It's not mandated for all of structural heart, and I do think that.
That's true.
Yes, here we have a very functional, effective team that permeates not just the TAVR world, but all of structural heart. And I'm not sure that that's the same everywhere. And I think that that's Shangri-La. You have everybody working together and tailoring the best therapy for the patients. And
so that's one thing cardiac surgery somewhat has kind of missed the boat on, is staying on top of mitral valve disease. So we don't have the same kind of oversight and scrutiny that we do with TAVR when it comes to consideration for percutaneous mitral valve options for these patients.
I think that
depends on the institution.
So I think certainly as the reason that evolved, as you know, was to try to keep the right decisions being made for the right reasons, in that having cardiac surgeons and cardiologists working together, it was felt would be the best way to come with the right decisions. I think as the interventional techniques get better, I don't think that should change our indications for what procedures we do. We still have to follow evidence-based practice. And again, it's not the techniques, it's the disease process that we should, in my opinion, be focused on.
Mm-hmm. So since we're really focused on training the cardiovascular surgeon of the future, how does the heart team relate to the trainees? I mean, what role do they play in the heart team, or do they?
Yeah, so typically, we have a meeting where we go over all transcatheter therapy patients, where we'll review their indications, review their imaging. We'll talk about why we would use one thing over another, things to watch out for in specific patients from an anatomic perspective. And so we have our trainees, fellows, folks that are spending extra time with us to do a structural heart year. They're intimately involved with the team and participating in those meetings and preparing cases and that type of stuff.
So next question is it possible to improve my technical performance, just looking at skills, outside the OR without a mentor, so as to increase my technical capability via deliberate practice?
Absolutely.
Yeah.
I think that one of the great advances in surgery has been the high fidelity simulation that exists at many places, and I think it's part of the requirements in general surgery, and will be a requirement in cardiothoracic surgery. I mean, there's incredible. I don't want to date you, Alan, but when we were, we used to sew bananas and chicken legs, and it was a way to learn how to cut and sew. But there's much better ways, not just to learn how to cut and sew, but to use scopes and wires and catheters that can really give you a high level of fidelity and improve your skills, I think.
Yeah, your significant other should always be complaining about those knotted silk ties that are on the armchair or something like that, because there should be dozens of them. But I mean, and to answer it seriously, there's different levels of sophistication of trying to do this. I mean, number one is just the basic things, and that is learning, or craft and trade is sewing and anastomoses.
Tying knots,
And again, as a trainee, the better you are when you come to the operating room, the more you're going to get to do. I mean, it's just quite as simple as that. If the first time you sit down, you don't know one end of a needle holder from another, well, there ain't going to be too many sutures placed in that anastomosis. And so that's the opportunity, is learn how to tie, learn how to sew anastomoses, learn how to close skin. And if you master those three things, then the rest of it's just about understanding the disease process and setting up the operation. And that's the other thing that you're probably going to have to learn from a mentor, because, I mean, everyone knows that, the resident's in there struggling, and the attending comes in and all he does is reorient the clamps and the retractors, and all of a sudden it seems easy. And that's part of the art of being able to do this. So yeah, I think practice is important. There are certain criteria. One of our partners, John Bismuth, heavily involved in building these endovascular models and trying to quantitate what that is. Always amazes me that there is no quantitation process. We equate numbers of cases with technical capability. And we know that's not the case,
Right.
and that's the problem.
I think one of the things that we sometimes overlook in that is that we have these great models, great fidelity. We ask our trainees to go out and practice on these things, but I think that the one thing that gets overlooked sometimes that would be a much better benefit to those trainees is have a dedicated faculty member that's going to go through and give tips and tricks and things that they may not think of, and show them how to do things, but then really let them do things and critique them on their technique and things, ways that they can improve. And I think that really adds to these simulation things, is when faculty is engaged and involved and actively helps out.
So, because it's not just practice, it's practice perfect.
Perfect, yeah.
And it's like watching the Golf Channel. You watch the Masters of golf, not necessarily the game, and you see how they do what they do, and you try to imitate them. And so it's not just getting into a simulator or on the chicken leg, to just throwing stitches in and trying to be as fast as you can. It's trying to be as perfect as you can, in my opinion.
One of the most focused I've ever seen our residents was that we said, a week from now at our conference, we're going to bring in these models, and everybody is going to sew an anastomosis, and we're going to give a prize for the best, and we're going to give a prize for the worst. It was pretty interesting. They were in there every night, because it's bad enough not being the best, you sure don't want to be the worst. Of course, we didn't actually do that, but it's all about using the right prompts to get the right response. Okay.
Fear is a great motivator.
When do residents need to start operating with patients and start their learning curve? We're all looking at you, Marvin, because that's a tough question.
So, I think, early on, operative experience and letting them do parts of cases is critical. I think you have to, again, having dedicated faculty geared towards teaching that's willing to give up portions of cases or the entire case, depending upon the resident or fellow's skill level. I think that's the key thing. You just have to have engaged faculty and allow them under appropriate supervision to learn.
I think it's a graduated level of responsibility, and that's where the practice can pay off. If you come in as a resident and you can tie knots really well, and you are technically, you can demonstrate that you're technically facile, you'll get to do more and more. And the converse is also true. Cardiac surgery is a highly technical specialty. You can't really teach somebody how to sew on somebody's obtuse marginal artery, I don't think. So, I think you can teach people how to open. I think you can teach pretty much anybody how to cannulate. And those are all skill sets that you develop on your journey towards being a good technical surgeon. So, the more you're able to do, the more you will be able to do.
Yeah, I think one of my observations about cardiac surgery, it is probably the single most audited specialty that is out there. It's just having your name up in lights. The idea that you're expected to do a coronary bypass, open somebody's chest, cannulate the heart, stop the heart, do these bypasses, restart it. with a 1% mortality rate is just shocking to me. And so I think there's a lot of pressure. I mean, the trainees always want to do more and more and more, but there's a huge amount of pressure on the attending to make sure that there's the best outcome that can be achieved with that patient, because it's not the resident's name who's going up at M&M, or in our case, when we report at our cardiovascular service line, it goes up by the individual attending. So it's pretty tough from that standpoint. And then, vascular surgery has always been envious that you had the STS database. I'm like, whoa, be careful. Be careful what you want. This it's certainly a huge role, but it's tough.
It's shocking to me sometimes when I go and see patients and you see all their medical comorbidities and they haven't taken care of themselves and all the problems with their organ systems, and we have the Society of Thoracic Surgeons risk calculator and you put in their risk of surgery and it's 1%.
Yeah.
I mean, there is no margin for error.
You go look back at the patient and look at the calculator and figure out what was put in wrong.
Well, but I think that speaks to how effective training in cardiothoracic surgery has been.
Yep.
And I mean, it's an inconvenient truth, but it's the truth. I think that over the years, that cardiac surgery had the luxury of being able to attract really smart, really talented surgical trainees who wanted to become cardiac surgeons. And I think that I have a brother who's a general surgeon that used to say, you cardiac surgeons, you always take, among the best of our trainees, and you take them away from general surgery, and we've already taught them how to operate, and you just teach them how to do cardiac surgery. And I think in the past that was really true, and it certainly allowed the selection process to see how somebody, as they were going through general surgery, had an interest in cardiac surgery, had the ability to be a really good surgeon, and they could be selected as such. And I don't think, certainly somebody coming out of medical school doesn't have much experience, or probably any experience, in cardiac surgery, so they're not really sure if they have the ability, the aptitude. Certainly senior surgeons haven't had the ability to evaluate that medical student to see if they have the ability, the aptitude, and that makes the calculus even more difficult.
Yeah. So interesting though, Tom, I had exactly the same reservations. I despised vascular surgery even when I was a first and second year general surgery, because I thought patients were too sick, too complicated, I couldn't figure it out, and I didn't get to do anything.
Yeah.
And so it wasn't really until very late on that I decided I wanted to be a vascular surgeon. I would never have gone into vascular surgery as a medical student. However, again, the medical students seem to have figured it out. There's been a boom in the number of people who are applying. And so then the knock-on effect could have been, there's half the class are going to be fired, are going to quit and go off. That's not happened, actually. There's very little movement that's actually taken place out of it. And so, maybe we don't give the medical students enough credit in terms of being able to figure out what they want to do.
Yeah, it's really tough to take a fourth-year medical student that has been on a couple rotations. Every case is the greatest thing that they've seen, and ask them to come up with a lifelong commitment to a specialty is tough.
Yeah, you know what happens? Because I always ask them, how on earth did you decide to do it? There's always a story. There's always a story that I rotated on the service. I worked with Dr. Atkins. He took an interest in me. He spent time. There's always somebody who has influenced that student to go into a particular specialty, and I think we've kind of pivoted to get medical students a lot more engaged and exposed to vascular surgery earlier on.
Well, that's definitely a trap that cardiothoracic surgery fell into, which was to not earlier engage medical students and junior level residents. And certainly the Society of Thoracic Surgeons and the AATS have started to do that now, to go out and engage medical students, to show them, there has never been a more exciting time to go into cardiothoracic surgery or cardiovascular surgery. The things that we're able to do and how well we're able to do them, it's better now than ever before. And so we just have to get the word out to everybody what a great specialty it is.
Yeah, I agree with you. In fact, one of our recent meetings, there was a panel I got mad, to be honest with you. I went on the panel, but it was nothing but gloom, doom, and despair from one presenter. I said, I don't think there's ever been a better time to be doing what we're doing at the moment. The opportunities are immense. The reimbursement's pretty good for what we get paid for. We're pretty valued.
The two leading causes of death in the United States is coronary artery disease and lung cancer. That makes up, more than half than what the leading causes of death. And those are two diseases that are very effectively managed by cardiothoracic surgery.
So let's try and nail down some of these questions. So we've kind of touched on this, but any advice for medical students interested in CV surgery?
Well, I think the most important thing is to find a mentor. So, we touched on that a little bit. Having somebody that's going to take you to the operating room, that's going to spend time showing you things, pointing out things as a medical student, maybe letting you do some type of part of the procedure if possible. That really ignites people's fire.
Yep.
Yeah, no question. And I think that as a medical student, going up and finding somebody who seemed, cardiac, thoracic, vascular, congenital heart surgeon, we were all medical students at one time. We all had a great interest and enthusiasm, and I think we still do. And I love having excited medical students around.
Yeah.
They make you think about things in ways that you used to think about when you were a medical student.
So there's an interesting question. Maybe a plant. With all the scrutiny of cardiac surgeons are under and the fact that most patients expect the staff surgeon to do the case, how do you allow the trainee to get involved in it? I think you really kind of talked about how this graded expectation.
Correct.
Yeah, I think that you can't compromise an operation because of having a resident do it. So I think that I think the hardest part of an operation is the judgment that goes into the operation, and that's where the attending can be very helpful in guiding the resident. There are some muscle memory techniques that may take some residents longer than others to develop, but you can't compromise the operation because you're training a resident. And I do think that the last 50 years have demonstrated that you can successfully train residents and successfully do operations despite the scrutiny.
Right. Tom, you've stimulated some folks to want to be a congenital heart surgeon. And maybe even longer to train than Marvin took. How do you do that?
Well, so there's congenital heart surgery is a very small subspecialty within cardiothoracic surgery, and certainly if you think that the level of scrutiny and the need for great technical ability is high in cardiac surgery, which it is, it's even higher in congenital heart surgery. So. I do think that if you think you have an interest in congenital heart surgery, I think you have to demonstrate your abilities as a cardiac surgeon first, as a cardiac surgery trainee, and then everybody now really has to go and do subspecialty training, and there is a board track to do that.
And congenital cardiac surgery has increased their training now, I think, to 2 years across the board,
right,
where previously it had been a 1-year subspecialty. And most people that come out of congenital cardiac surgery these days, once they get their first job, it's usually several years of kind of mentorship from senior partners before they're doing independent cases, especially complex things.
All right, a couple more questions and then we'll pivot. Is there an evaluation grid for technical skills? I think the answer to that is no.
Not really. Yeah.
Well, there are the milestones that they have in the TSDA, and part of the clinical competency committee is that there are skill sets that the trainees are supposed to meet to go and progress to the next level. And I think we've all seen it. There are some residents who are just really technically gifted. There are some residents that take longer. It's funny, when I was come from a big family, and when we started having kids, we'd all call my mother up and say, "Geez, Mom, so and so, started walking at 10 months," and another one would call up and say, "Mom, I'm a little worried. It's now 11 months, and so is not walking." And the mother, as wise as she was, would say, "Well, yeah, some kids walk early, some kids walk late. By the age of 3, they're all walking. And I think that that's true with residents. I think that there is a learning curve, and the slope of that's a little bit different with different people.
Okay. What are the non-technical skills do you think important that a cardiovascular surgeon should have? The answer, none.
Ouch, that hurt.
Go ahead.
So I think the most important thing is judgment about these cases,
Yeah.
and so that obviously comes with experience, and good judgment comes from bad judgment, they say. So I think that's probably the most important thing is choosing the right patient to be able to get these optimal results that everybody expects, knowing who not to operate on.
And I think too, I think the non-technical skills, as you pointed out, the heart team, I think teamwork, it's a team sport. And I think you have to work well in a team. And I do think that, I think certainly historically, we all trained as individuals, and I think appropriately now the training and the focus is on the team and being an effective and respectful member of the team.
All right. Well, I'm going to pivot the conversation to the hot topic of the moment, and that is COVID-19. And focus it on the impact on our training programs. What we've done here recently is split the attendings into 2 teams, split the residents into 2 teams. We have basically gone down to semi-emergent or /emergent, and so we've gone down from running 11 cardiovascular operating rooms a day to 3. And I think we all agree if this lasted 3 weeks, no big deal. It lasts 4 or 5 months out of a 2-year fellowship training program in cardiac or vascular. What are we going to do about that?
Yeah. So if you take a quarter of somebody's experience in cases and take that away, that's going to have a huge impact. The crazy thing is we have no idea when the end is in sight for this. So, maybe residents are going to have to stay longer. Maybe they may not even make their case requirements, which is a big concern.
Well, that's part of the, I know we're not supposed to say problem anymore, we're supposed to say challenge, but it's a problem. Yeah. In that the way you qualify to take the boards is the case list. Mm-hmm. And there's a certain number of cases that you have to have and a certain number of index cases you have to have. And for the most part, we've gone through a period where training programs are able to do that. We now face what is arguably the biggest healthcare crisis in our lifetimes, and that it's going to take time away from us taking care of cardiac or vascular or thoracic patients and taking care of a vast multitude of patients who are going to be sick with COVID-19. And I do think there's a lot that our residents and our fellows will learn from taking care of those patients. It's not going to add, and it's certainly going to take away from their case lists, but I do think it will be valuable education for them.
Well, it's interesting because the 2 residents that I mentioned in our vascular program who are applying with cardiac are doing video interviews at the moment. Yeah. Would you hire somebody based upon a video interview? I would have reservations. I'd never say no, but I'd be doing a lot of calling to the people that they work with who are friends of mine who
extreme times call for extreme measures.
Yeah.
I'm gonna fall into your trap.
What's that?
Because so if you had asked me 2 years ago, would I be willing to see patients in a video visit?
Yeah.
I would have said, what are you, crazy?
Yeah.
You need to be able to see the patient, talk to them, shake their hand, examine them. Well, I spent the whole morning yesterday doing video visits, and it worked really well. Mm-hmm. If you'd asked me 5 years ago, what do you think about the virtual ICU and using the video to care for patients in the ICU, I would have said, what are you, crazy? Kind of like what they probably asked Marvin when he applied for his cardiac residency. And it's a very effective tool, and I think that we just have to. If you said, certainly I know if you asked most cardiac surgeons 10 years ago, if you thought we'd be replacing aortic valves with transcatheter therapies, would say, what are you, crazy? But it's not totally crazy. I think we just have to continue to, if that's what it takes, that's what it'll take. So yeah, maybe I would.
Okay.
Yeah, I think it's going to be tough this year, especially since half of the interview season was over. So people were able to go to maybe half of the places.
Exactly.
So
Somebody can write a paper about that.
Yeah.
That's a very interesting observation, Arson. Do you preferentially select the people
somebody you
you
saw in
see
person,
in person?
and got a feel and a vibe for versus some video type of visit.
Yeah. But, I mean, so we're trying to run our didactic education programs online. We use Zoom. It seems to work pretty well. Right. So we can supplement to some extent, but there's still going to be this technical gap.
Right.
Anything they can be doing at home?
Yeah, I mean, again, a lot of the simulation techniques that we have here, housed in Mighty, which is our simulation center, really you can't bring large groups of people together to work on those. So maybe we, put together 2 or 3 people to come at a time, stagger them to come work on different models, endovascular trainers, high fidelity type of open model technique and practice, but stagger it so there's not a whole lot of contact. Maybe we need to think about doing that.
Well, I mean, there's a knowledge component of it, and it's, there's now more time for people to read and to use online resources. And I agree. I mean, I think the skill sets, those are things that we're going to have to get creative about. Getting people to keep their hands busy. I think we have a great. Mighty is a great simulation center. I'm not sure everybody else is so fortunate.
Closed. Can't bring anybody up there right now. That's, I mean, this is one of the problems. But I do think, rather than being pessimistic about not being able to operate, to your point, this is a huge opportunity to read and write and build your knowledge base. And so don't squander it. I mean, to be honest, one of those things you'll look back 4 or 5 years from now and go, oh man, I need another one of those COVID things that I can actually spend some time reading, So it's look on it as an opportunity, rather than, I can't get my hands bloody and operate on a daily basis.
Yeah, we better have 30 or 40 publications from our residents.
Right, exactly.
Things over with.
But I do think it's going to be a challenge for the societies or for the boards to go, okay, well, what are we going to do with this cohort of residents? I mean, let's say you have somebody who you don't think is quite where they should be. Maybe they weren't going to be quite where they should be regardless, but now there's a built-in problem, and that is that there's the COVID excuse.
Right. Well, but I mean, is this really any different than World War II? I mean, all of the, not just the surgeons, but the physicians of training age were left. And certainly for surgery, they got surgical training, but it was a specific kind of training, and I think it's a similar kind of experience. I think that we have the benefit in medicine that we have very intelligent people who have demonstrated incredible ability to be successful in whatever they do, and I think that this is no different from times past.
Okay, one other question. What do you think about decreasing demand for cardiac surgeons? Is cardiac surgery a dying specialty? Thank you.
I really think it's the opposite. When I was initially looking for jobs, I mean, the job market is crazy. In terms of, not just academic practice, but also out in community practice. I mean, the job market is great these days.
As I said earlier, I mean, it's never been a more exciting time to be a cardiothoracic surgeon. Those diseases aren't going away anytime soon. And I think that, certainly, if you look at the number of coronary artery bypass operations that have been done, sure, compared to the 80s, it went down. It's going up again, as the effectiveness of CABG for coronary disease has been demonstrated time and time again as being effective. I think that are we going to be replacing aortic valves differently than we did before? Well, yeah, but I think, as Marvin pointed out, I mean, cardiac surgeons are part of the heart team. There's electrophysiology that the surgical treatment of arrhythmias, aortic disease, structural heart disease, mean, there's a lot of different things, the adult congenital heart disease, transplantation, mechanical circulatory support. These are all new fields that are part of cardiothoracic, and I didn't even talked about general thoracic surgery. But these are all specialties that are blossoming, and the need for people to be able to do them is going up.
During this COVID crisis, I mean, we had a little webinar the other day about ECMO, and what's the role of the cardiovascular surgeon going to be in taking care of these patients?
So we talked a little bit about that yesterday. So, what we're seeing internationally and so far in the United States is that the role for ECMO in COVID-19 patients so far has been relatively limited. In our experience here, which has been, seeing patients for about 3 weeks now, we've placed one patient on ECMO. We may have a second patient. Up in New York, my understanding is there's maybe 3 or 4 patients at the various hospitals. So I would suspect that the role may be small, but there are going to be patients that this is their last resort.
If you've got it,
I couldn't disagree more.
Yeah.
So I'm more than just ECMO cannulator or decannulator. I mean, I'm a physician first, a surgeon second, and a cardiac surgeon third. I didn't spend almost a decade in training just to be focused on ECMO cannulation and decannulation. Sure, we can do that, but we spend all of our time taking care of really sick patients. So we're expert surgeons, we're intensivists. We have the ability to evaluate people who are sick and not sick. And I think that we may have to dust off some of those skill sets as the ICUs and the wards are being overwhelmed with sick patients. But I think that we have the education, the training, and the ability to meet those needs.
I get the point of your question.
So we've actually had a discussion. Do we need to be tuned up by our anesthesiologists in intubation? Do our vascular surgery group need to be taught about ECMO cannulation? Because there are not a lot of cardiac surgeons and vascular surgeons. You can take out half that team pretty easily and get down to bare bones. And the question is, what do we need to do to build next guy up, kind of thing?
So what we've done is we have taken our team and we've divided it in two. And I'm not sure this is the right way to do it, but this is the way we've done it. One team is gonna be responsible for all of the responsibilities for cardiac surgery for 2 weeks, and then we're going to change. We're going to tag team, and the other team will come in and have the other team go in, so that we can hopefully keep a healthy group out of the hospital and trade off. We hope nobody gets sick, but our second hope is that if somebody gets sick, not everybody gets sick.
Right. Yeah. And the role of residents in taking care of the COVID-19 patients. We've kind of gone through an evolution. I mean, first of all, our GMA office came out and said they will not be treating these patients. I mean, it's unrealistic as we start ramping this up. And so now we've kind of changed that. They need to be trained with PPE, etc. But they're now just part of the team that's going to be taking care of the patients, much like we are, and much like the intensivists are.
So when you were a resident, Alan, if they told you weren't able to take care of these sick patients,
you'd rush towards them. You'd be mad.
Yeah. I mean, I don't. I think everybody. Yeah. I think that our residents are, as I said, smart, talented, wonderful people, and we should ask them. I mean, we should ask attendings. Do you feel comfortable taking care of these patients and understand the risks that are part of it? And if they say yes, I do, and yes, I want to, I think we should honor and respect their decision on both sides of that. As for attendings, my opinion.
Well, that's probably a great note to end it on. You have a final comment?
No, I think it's a wonderful time to be a cardiovascular surgeon. I definitely recommend anybody out there who's watching this webcast, podcast, If you want to look at the different training paradigms, we're happy to discuss things further, or find a mentor, somebody that can help you sort through some of the stuff, especially if you're in the medical student age range, trying to figure things out in life. Having some type of mentor to help you figure out these training paradigms is paramount.
All right. Thank you both very much.
Yeah, thanks, Sean.
Thank you for
Thanks,
watching.
Marvin.
That was wonderful.
Yeah.
Thanks.
Thanks, everybody. I think you're absolutely right, Mark.